Okay, you've got a spine question on step 2 CK. So step 1 is always triage. Forget all the extra noise they throw into the vignette. Your brain needs to immediately categorize the pathology to unlock the correct algorithm. We are treating this explainer as your ultimate test day decision logic. Let's get right into it.
Your absolute first reflex has to be instantly spotting structural red flags to determine the exact path of your algorithm. Are we looking at trauma or non-trauma? Is the issue in the neck or is it in the low back? Does the patient just have pain or is there a hard neurologic deficit? You must explicitly scan that question stem for bowel or bladder symptoms, fever, IV drug use history, immunosuppression, or constant night pain. These are your branching points. Honestly, if you miss these, you're going to miss the diagnosis.
Let's actually test that reflex right now. What's the underlying board-tested pathology when you see this classic constellation of upper motor neuron signs? We're talking quadriparesis or quadriplegia combined with ataxia and incontinence in a Down syndrome vignette.
If you said atlantoaxial instability, you nailed it. The core clue here is cord compression, resulting directly from excessive mobility between the C1 and C2 vertebrae. And this perfectly explains why symptomatic atlantoaxial instability absolutely demands surgical fusion of C1 and C2. When the spinal cord is actively being compressed, giving you those upper motor neuron signs, conservative management is entirely off the table.
So, let's look at how this builds out our differential for neck pain. If you've got an older individual with pain and stiffness that gets worse with movement but better with rest, you're looking at facet osteoarthritis. Contrast that immediately against spinal metastasis, which presents as constant pain that's notably worse at night and stubbornly refuses to respond to position changes. And if the vignette suddenly throws in focal tenderness with fevers, night sweats, or recent IV drug use, your mind must snap straight to vertebral osteomyelitis.
Now, what's genuinely fascinating here is the binary contrast between two incredibly high-yield pathologies. On one side, cervical radiculopathy is typically abrupt, usually from a disc herniation. It shoots pain radiating down the shoulder and arm with strict dermatomal sensory, motor, or reflex findings. You'll see a positive Sperling's test, and crucially, the shoulder abduction relief test reduces tension on the nerve root. But on the flip side, cervical myelopathy is a subacute, progressive narrowing of the canal in an older patient. Myelopathy hits you with lower extremity weakness, gait dysfunction, bowel or bladder issues, and that famous electric shock-like Lermit sign when they flex their neck. Here is an absolutely crucial point to remember. Mild cervical radiculopathy is purely a clinical diagnosis. Do not jump to imaging. You treat initially with NSAIDs and just strictly avoid any provoking activities. You should only order that MRI if you hit the severe red flags. We're talking progressive or bilateral neurologic deficits or a really high clinical concern for malignancy or an epidural abscess.
But myelopathy? That plays by a totally different set of rules. If the patient is older, with lower motor neuron signs in the arms, like muscle atrophy and hyporeflexia, but upper motor neuron signs in the legs, like a positive Babinski and hyperreflexia, your reflex must be an MRI of the cervical spine or a CT myelogram. This degenerative canal stenosis, leading to cord compression, requires either non-surgical immobilization or definitive surgical decompression.
All right, moving down the spine a bit, let's talk vertebral compression fractures. The classic presentation is acute back pain and decreased spinal mobility following what's often just trivial trauma, but in patients with underlying bone weakness. Think osteoporosis, osteomalacia, metastases, hyperparathyroidism, or Paget disease. The pain uniquely increases with standing, walking, or literally just lying supine on their back, and you'll find point spinal tenderness right at the affected level. Chronically, this shows up as painless progressive kyphosis and a loss of height.
You know Step 2 absolutely loves to test lookalikes, right? So you have to relentlessly contrast neurogenic claudication from lumbar stenosis against vascular claudication. Lumbar stenosis pain is positional. Lumbar extension, like standing upright or walking downhill, worsens the pain. Spinal flexion, like leaning forward on a shopping cart, the classic grocery store sign, relieves it. And their lower extremity pulses, completely normal. Vascular claudication, however, is purely exertion-based. The pain reliably comes on with walking and is relieved strictly by rest, plus it's accompanied by decreased pulses, a cool extremity, and pallor. You diagnose that with an ankle brachial index.
Now take a look at the forward slippage of the L5 vertebra over S1 here. That's your visual anchor for spondylolisthesis. It's a classic structural defect, often stemming from bilateral fractures of the pars interarticularis, which is known as spondylolysis, progressing to actual vertebral displacement.
You've got to instantly recognize this classic clinical script.
It's almost always an adolescent going through a growth spurt, doing sports that require repetitive extension and rotation, like gymnastics or diving. They come in with low back pain that gets worse with extension, and crucially, you feel a palpable step off on physical exam. When you see this, get the X-ray to diagnose it, but hold off on the MRI and surgical consult unless there are actual neurologic deficits or the symptoms are dragging on past 90 days. Activity modification is your go-to first-line management.
Okay, let's dive straight into the algorithmic pathway for non-traumatic back pain imaging, because honestly, this is where points are won or lost on test day. Every single patient with acute back pain under 4 to 6 weeks needs to be run through this exact mental flow chart.
The absolute golden rule: uncomplicated acute back pain gets zero imaging. None. You have to resist the urge to click that MRI button. You just continue conservative pain management. But you immediately order an emergency MRI if you see significant neurologic deficits like urinary retention, incontinence, saddle anesthesia, or lower extremity weakness involving multiple nerve roots. You also pull the trigger on an MRI, maybe adding an ESR or CRP, if you suspect infection, like fever and IV drug use, or malignancy, like a cancer history combined with systemic weight loss.
Let's test those imaging rules real quick. A patient presents with low back pain after lifting a heavy box. The pain radiates down the posterior leg to the foot. The straight leg raising test is positive, but the neurologic exam is completely unremarkable. So what is the best next step in management for this patient with radiating pain but zero red flags? The answer? A trial of NSAIDs and activity modification, not an MRI. You manage both lumbosacral radiculopathy and, well, actually, you manage both that and a simple lumbosacral strain initially with NSAIDs, but pay close attention to the specific presentation. Radiculopathy, typically from a herniated disc, radiates past the knee down the leg and gives you a positive straight leg test. A simple lumbosacral strain, which is the most common cause of acute back pain, by the way, stays above the knee, presents with localized paraspinal tenderness, and has a totally negative straight leg test. Since neither scenario, without red flags, changes your immediate conservative management, imaging is simply the wrong answer. Right now, let's pivot over to trauma. For cervical trauma, your first move is always immobilize the cervical spine before you do anything else. Once they're immobilized, evaluate the mechanism of injury. If it's high energy or if they meet the nexus criteria, you go directly to a CT of the cervical spine. So what exactly are the nexus criteria? We're talking a focal neurologic deficit, midline spinal tenderness, altered mental status, intoxication, or a distracting injury. If they meet even one of these criteria, you image. And here's the kicker. If you do a CT and find a single vertebral fracture anywhere, your immediate test day reflex has to be to image the entire spine. A single fracture in blunt trauma is an absolute indication to clear the rest of the spine because the risk of non-contiguous fractures is just incredibly high. I want you to lock this rapid summary into your visual memory. It'll help you instantly recognize these diagnostic contrasts and absolutely dominate your Step 2 spine questions. The difference between passing and excelling isn't just knowing the random facts. It's knowing precisely when to deploy the imaging, when to hold back, and how to spot the one specific red flag that changes the entire management pathway. Mastering this structured decision logic isn't just about getting a good score. It's the ultimate weapon to transform test day anxiety into pure clinical confidence. Once you see the matrix, you won't unsee it.